Hello.
Do I need this microphone? Can anybody? Yes, you do at the back. Do I need it? I don't like microphones. Yeah, apparently I need to use it. I'm not Tom Jones, you know. Right. Welcome, everybody, and really thanks for coming out tonight. My name's Kevin Dixon, and I've been asked to independently chair this one. This is a meeting on the, just in case you ended up in the wrong meeting, this is on the Strategic Transformation Plan, and it's shaping future care in our part of the world. I'll introduce myself properly in 5 minutes' time. I just need to do the sort of the housekeeping-y things. So the first thing is, you probably found them already. Toilets are out the back. The disabled toilet is cunningly hidden just round this corner, and it took me 5 minutes to find it. Fire escapes are there and there. We're not expecting a fire drill or anything like that, so if the alarm goes off, it's a real one. So follow me, because I'll be in the front of the queue. And we've got refreshments over there. Everybody got a tea and coffee? Everybody sorted out as they came in? Yeah, because I made sure you two did, so very much. That's great. So tonight we're going to look at the agenda, and I've got the little clicky thing somewhere. Okay. So the agenda first, if I can see it. Yeah, so welcome and introductions. That's me, Kevin Dixon, and I'll say who I am in a minute. Then we're going to look at a STP and an acute presentation, which is going to take about 30 minutes. So we've got a nice video. If it works, and I just don't like technology, if it works, that will be coming up next. And then we're looking at a question and answer session from the panel, and I'll introduce the panel in a few minutes, or let them introduce themselves. And then what we're going to do is we're going to do table discussions. And the reason we're actually doing these table discussions is because we've asked an awful lot of members of the public how would they actually like to feedback and and how they actually sort of feel about meetings. And rather than people being in row after row, people prefer having an opportunity to talk in smaller groups. So that's the reason we're doing it. So I just want to let you know that one. And then we'll close the meeting after about 60 minutes. And what will happen is on these tables there will be a member who's of probably the clinical commissioning group, who is actually going to sort of help facilitate those tables, to sort of draw out your questions, draw out your concerns, and see how we can actually start shaping health and social care in the near future. So that was really what the agenda is. Me. I just thought I'd say that who I am. My name's Kevin Dixon. I know quite a few people in the audience, and I certainly know an awful lot of guys outside. So. Yeah, they're just waving at me. And I know the folks outside as passionate as you are, and as passionate as I am, and as passionate as are all the guys on the front table here about the health service. And I've always thought we're actually on the same side. My personal background is a carer. I don't know that much about the health services. My dad was disabled for 20 years and needed full-time care for about 6 years. And I just want to thank you guys for looking after him. I mean, it was remarkable. And the other thing I'd like to say is, and I'm not going to take my shirt off, if I did, I've got a whacking great scar down my tummy. And so the NHS saved my life. So again, that's another reason why I'm deeply passionate about the NHS and how we sort of shape health and social care in South Devon. Okay, that's probably it. So what I'd like to now do is actually ask the panel to introduce themselves.
Thanks. Yeah, okay. Thanks, Kevin. So my name is, I'll just stand up so that people can see me at the back. My name is Dr. Nick Roberts. I've been a GP in the area for 24 years. 2 years ago, I took up the role of Chief Clinical Officer of Torbay and South Devon CCG. And I also work as part of the STP, the Sustainability and Transformation Plan, and we'll talk a bit about what that means later.
Good evening, everyone. I'm Rob Dyer. I'm Medical Director of Torbay and South Devon Foundation Trust, which is the organisation that provides care at Torbay Hospital, but also the community hospitals and all the community services across Torbay and South Devon. I've been doing that for a year and a half. Before that, for the last 17 years, I was a consultant in diabetes at Torbay Hospital.
Good evening, everybody. My name's Annette Benny. I'm the Interim Director of Corporate Affairs at New Devon Clinical Commissioning Group, which is the other clinical commissioning group that covers Devon, together with Nick's team. I've a long and varied career in the NHS, starting off as a podiatrist a long time ago.
Okay, thanks very much to the panel there. And I think we just now go straight into the presentations. And who's going to do that for us to start with?
I'll kick off, Kevin. I'm going to move around the front because I'm being blinded by that at the moment. So, yes, so the Clinical Commissioning Group, as detailed, we hold the budget for providing health care. So that's purchasing services from the acute, the hospital, also things like mental health. We have a joint contract also across in Torbay to have a budget which links across to social care. But that's only in Torbay as against South Devon, whereby Devon County Council hold the social care contract. So about tonight, we hope we'll give you some background about the Sustainability and Transformation Plan. Can I just ask briefly, how many people have heard of a Sustainability and Transformation Plan for health? That's pretty impressive. That's good, because I think they've had a slow development, really, and I think certainly the one, generally speaking, they were not launched particularly openly, and some of the plans were not shared immediately. Fortunately, the Devon Sustainability Transformation Plan was made public and is on our website, should you wish to know the detail of it, and you've got some outline documentation of it there. So we want to explain why we're reviewing acute hospital care, hear your views on what's important to you as we make decisions about acute services, explain how we will use your feedback and inform the plans and the process that will go forward. So this is an inaugural event, but there will be a process that follows on from this, and how you can stay involved and keep updated to know what is actually happening. So this is a very open process to involve the general public. So the Devon STP was launched towards the middle of last year. It is one of 44 STPs, Sustainability and Transformation Plans, that are launched across Britain. So R1 covers wider Devon, roughly 1 million population, and has 4 acute hospitals within it. So that's Torbay, which most of this population receive their care at, Plymouth, Exeter, and then Barnstaple, North Devon. The plan is necessary because you and I know that there is incredible pressure within our systems. Whether that's within our primary care services, GPs, where there's issues around recruitment and workforce, whether that's in our community services, where there's issues particularly around domiciliary care and supporting people at home, and also in our acute hospitals. So that's our emergency departments, which you will know, despite a pretty good winter actually for our area. Generally speaking, A&Es are incredibly busy places and often suffer episodes of overcrowding. So we know there's incredible strain within our system. We also know part of that is around people living longer, people living with long-term conditions. By that I mean diabetes, heart disease, and that these people need care, need ongoing care, need input, and need quick interventions when crisis strikes. So that's part of the reason why we need to have that. We need a better integrated health and social care system. We know that at the moment, if you're trying to look after a loved one at home, the complexity of the system of whether that's health looks after you, whether it's delivered through your GP, whether it's through nurses, physiotherapists acting in the community, or is that through social care, providing care and provided by local government. At the moment, it's an incredible quagmire to navigate your way through the complex funding systems and who does what. And so we need to work together to simplify that for all of us and for those that need that care. I've touched on increasing demand. We also need to think about how we utilize technology better. We're a rural community, and as such, I don't think the NHS really manages the way technology could be used to work more efficiently with our community. I had the misfortune 2 days ago to break down with a puncture in the back lanes out Devon. I downloaded the AA app and it tracked the AA vehicle coming to my car, and he met me there, within an hour. We don't have that technology to map when the ambulance is going to arrive, so that you know immediately that the ambulance is on its way and then it's within 5 minutes of being there. It seems amazing we don't have that technology within the NHS, and part of the Sustainability and Transformation Plan has a big IT component as to how we actually get in line with what actually happens within the private sector. So the Sustainability and Transformation Plan is not being cooked up by a bunch of individuals that don't work within the NHS. These are all the agencies that are involved in the Sustainability and Transformation Plan. So that's the 2 CCGs, all the acute hospitals, mental health trusts, and local government, Devon County Council, Torbay Council, and then Live Well in Plymouth as well. So these groups, these organisations have come together to work together collaboratively to develop a plan to meet the needs of our population across Devon for the coming years. And there's a short video now to talk to some of those members that are pulling this together and to outline some of the problems that we're trying to address with the STP.
There is already much to be proud of about health and social care services in Devon. Staff work hard to provide good care, local people are relatively healthy compared with other parts of the country, and local organisations already work together to meet the needs of local people. However, services are not keeping pace with the changing needs of local people, and it is becoming increasingly difficult to make sure that local people have access to consistently high quality care that is affordable and sustainable. There are a number of reasons for this. People in Devon are living longer, with increasingly more complex care needs that require more support from health and social care services. Some people have more health and social care needs than others. 40% of local people use almost 80% of health and social care. There are 400,000 local people living with one or more long-term conditions, and their needs are complex. Around 150,000 people have a mental illness. Doing nothing is neither affordable nor clinically sustainable. We will be more than £500 million in the red by 2021 if nothing changes. Although there have been some local successes in changing the way services are delivered, there are many challenges facing health and social care in Devon.
There are health inequalities across Devon. A person living in certain areas of Ilfracombe is expected to die more than 15 years earlier than someone living less than 2 hours drive away in Newton Poppleford and Hertford.
Local hospitals are finding it difficult to deliver services for some of the most seriously ill people. These include stroke, maternity, A&E and children's services.
Less money is spent on health and social care in the most deprived areas. Over 10% less is spent on health care for each person in West Devon compared to North and East Devon, even when age and deprivation is taken into account.
There are too many people in hospital beds who don't need to be there. The longer people stay in hospital, the more likely they are to get complications. It is also expensive to keep someone in hospital when they don't need to be there. The main reasons for delay are people waiting for health or social care in the community.
Care needs to be more person-centred and coordinated, especially for people with more than one long-term condition. People do not get enough support to be independent and are going into hospital when this could be prevented. This is particularly important for end-of-life care, where most people would prefer to die at home, but only a quarter are able to do so.
This is also true for children. There are high levels of demand for child and adolescent mental health services, and there are still far too many children in care or in highly specialist placements, often many miles from home.
Services could be run more efficiently across Devon. Tens of millions of pounds is being spent on areas where staff may be able to provide the same quality of services but more efficiently. Too much money is being spent on temporary or agency staff in hospitals.
Around 95,000 people with a long-term condition also have a mental illness. These people consume a large proportion of the health and social care budget but still achieve poor outcomes. They're also more likely to die earlier in life compared to people without a mental illness.
There are difficulties with recruiting and retaining staff at all levels, making it hard to provide comprehensive and high-quality services. Many staff are due to retire in the next 10 years, and local organisations already have high levels of vacancies and staff turnover in many areas.
People in Devon deserve health and social care services that are of the highest quality and are delivered as locally as possible. Local people should be supported to take responsibility for their own health as much as possible. If people do become ill, they should sit at the heart of a proactive, person-centred care system. Achieving this kind of transformation with the funding that is available is not an easy task. But by working together, the NHS and social services with other public, private and voluntary sector providers of care can get the best possible outcomes for local people.
Okay, so that highlights some of the issues which we want to touch on this evening. So the STP has 3 key areas of focus. One, as came up in that video, is about health and well-being. So that's about having an agenda that helps people to live healthy lives, take exercise, get advice at the right time. And for that to be accessible to everybody, as highlighted in that video, if you look at Devon, there's 15-year life expectancy gap between parts of, depending on where you live in Devon. Now, some of that can be addressed by health, some of that can be addressed by social care, but a lot of that also has to be addressed around housing, jobs, and other determinants that determine our healthy living. And that's why we've got so many people involved in delivering the SDP, including local government. The next thing is about care quality. We know that the quality of care is not the same everywhere across Devon, and therefore we have to ensure where there are gaps that these are filled. And particularly there's a big agenda around mental health, which has traditionally been underfunded as part of healthcare. And the last part is about financial sustainability. So we, as the clinical commissioning groups, have an allocated budget from the Department of Health and NHSE, and we have to live within that budget. And as in that video indicated, we are currently overspending our budgets. So we have to look at where can we make savings and where can we use the money most effectively. And that's part of involving the people in this room in making those decisions and supporting the processes we go through. So the STP has 7 elements, which you can see for yourself. Children and young people, the prevention and early intervention agenda, the health and well-being, the integrated care, and part of that is the consultation we did about community care, bringing community services and social care together. Primary care, which is what is delivered within our GP surgeries. Mental health, as I discussed. Productivity, and that's about being efficient, avoiding any wastage, sharing staff and services wherever possible. And the last one that's ringed there is acute hospital services, making sure we can access high quality acute services when we need them, that they're available and staffed and the workload issues are addressed. And I'm going to hand over to Rob now, who will talk you through the acute services review, which he is part of.
Thank you, Nick. Yes, thank you. The last time I was standing in this hall was for a meeting about community services about 6 months ago. And it's important to say that this meeting is not about community services, although clearly there is a close link between community services and the hospital, the acute hospital, large hospital services that we're here to talk about tonight. And I've no doubt we'll come back to that later. Nick's described the STP and its scope and scale. It's huge, a huge task to review the services that we provide across all those specialty areas. And so we had to decide where we would start. And the areas that were chosen as a starting point were the urgent and emergency care services, stroke services, and maternity, paediatrics, so children's services, and neonatology. This is newborn babies. And the reason that those services were chosen was because those were some of the services that are most vulnerable. And they're, of course, really important services for all of us, and I'm sure you'd agree that if those are vulnerable, it's an important place to start. So the video describes some of the reasons why those services are under pressure, and that increased pressure, if we do not reorganise how we work, will lead to longer waiting times if it hasn't already done so. It's important to say that a lot of the hospital services that we work in now were designed a long time ago. We had two ways of seeing patients, really. One was in a bed, a hospital bed, and one was in an outpatient clinic. And there are many more ways that we interact with patients these days, and so we can redesign our services in very different ways. There are also many more members of the healthcare team who can share the workload rather than just doctors and nurses. Additional pressure, in a sense, is also being imposed by new standards, and we have to welcome new standards of care which improve care for patients and reduce the risk of dying in our hospitals and so forth. But clearly those do impose additional pressure on our staffing levels. And all the time there are new treatments and drugs available for the conditions that we treat, which again is good news, but that brings with it additional cost and additional pressure on services. All of that, if we do nothing, will lead to us failing to meet key NHS targets and quality standards. And so our main purpose in this review is to reverse that direction of travel and really get back on track. We have, one of the biggest problems we have is enough staff, and I think that's particularly highlighted in those services where we need to provide services across the whole 7-day period, and that is for all of these services that I'm describing. So that's really the background to why we're here and why we've chosen those specialties to start with in our review. So I'll just quickly run through the specialty reviews that are going on, and I'm very happy afterwards to answer questions about the detail of how these are being undertaken. The first is that review of urgent and emergency care services, and this is being led by my colleague Adrian Harris, who's the medical director at the RD&E. It's important to say that each of the medical directors is leading one of these reviews, and we are in effect doing that on behalf of the group of medical directors. One of the really important things and really positive things about the STP is that it's brought together the staff working in hospitals in a way that they've never worked together before. And I can certainly vouch for the relationship between the medical directors as being extremely positive, and I think that's going to be a very important thing going forward. So the reasons behind the pressure on our emergency care system are increasing demand from patients with an aging population and more complex conditions and so forth, as was described in the video. But also this requirement to meet new standards for 7-day services, and in particular the requirement that very severely ill people are seen within an hour by a senior member of medical staff, and I'm sure we'd all agree that that was an appropriate thing to happen. In some parts of Devon, staffing shortages within the emergency departments and the supporting services are really becoming quite critical, and so we need to look at how we can work together to ensure that patients remain safe and our services remain resilient. It means that we have an inability to flex when we meet variations in demand, which is part of everyday life in an A&E department. It means that we're struggling to meet national targets, and the one that's publicised most often is the 4-hour wait, but there are many other markers of quality of care that we we need to achieve. And I've already talked about the high numbers of very sick people with complex needs that we need to be able to look after. The second area is stroke services, which is being led by George Thompson, who's the medical director at North Devon. And again, one of the major problems here is enough medical staff, senior medical staff, to provide the services that we need. We have real difficulty in Devon in that the population is, compared with some of the urban areas in the middle of the country, our population is quite widely dispersed, and we have 4 hospitals covering a population which perhaps in the Midlands would be served by 1 or 2 at most. And that brings with it some difficulties in providing resilient medical and nursing cover. Don't want to see that picture any sooner than you have to. The fact that we have this variation in service across Devon means that within stroke care there are different outcomes. So some parts of Devon you may have a better outcome from your stroke from others because of the variation in care and because of the time it takes to get to that stroke unit. And we believe that's unacceptable, and we need to work very hard to reduce that variation in care. This is related to partly to the time that they're travelling to hospitals, but also to the services and how they're configured, so that some people can take longer to get to much needed urgent stroke care. And the last of the 3 reviews, which I have the pleasure of leading, it's enormous, the whole of maternity, children's services and neonatology. And again, the problem here, once again, is those staff shortages, particularly in medical staff. At the moment, we don't have a problem with nursing staff and midwifery, but there are concerns that in a few years' time there may also be staff shortages in those areas as well. As a result of that, and the need to provide emergency on-call for all 4 hospitals, we have a high use of agency staff, which is not only expensive, but also makes it hard to guarantee the quality of care, as we have temporary staff moving in and out of our hospitals. It's becoming more difficult to provide resilient service 24 hours a day, which of course is vital for patient safety. And there is potential for us struggling to train sufficient staff in the future for our services. Another issue which has been highlighted is quite marked variations in the choice that women have for delivering a baby over the whole of Devon. In actual fact, in South Devon, we probably are in the best position. We have a relatively high rate of home birth, and we have a midwife-led unit at Newton Abbot. In some parts of Devon, there is no midwife-led unit, and we know that means that some women are not getting the care that they wish for and the care that is best for them. So, why are we engaging with you? Well, we have, within the STP reviews, we've pulled together large groups of people who work in our services, and they bring a fairly broad experience of those services, but of course they're bringing a professional's point of view to that debate about how services should be organised. And it's absolutely key that we have your views about how services should be organised. In particular, this evening, we're hoping to get your views on how we should determine, we will come up with a number of scenarios of how services could be reorganised, and we need your view about how we should determine which of those takes preference. So what are the important factors to take into account when we're considering how services could be reorganised? So your views absolutely will inform our thinking as we develop possible options for service redesign. It's important to say that none of these reviews have completed. There are a number of scenarios that have been identified, but they are in the relatively early stages still. So it is perfectly timely for us to feed in any thoughts that you have about how services could and should be organised. And the criteria that we've come up with so far, which we'd like some views on, are these. So and these have been pulled together by groups of doctors, nurses, therapists, social workers, and actually with quite a bit of input from Healthwatch within the clinical cabinet, which is one of the big committees within the STP. Healthwatch have been a very frequent, a permanent contributor to that meeting. And I hope you won't be surprised or disappointed to see that safety is absolutely at the top there. I think it's likely that in all of the reviews that safety will be given the highest priority. We need to be sure that any change in service is at least as safe or preferably more safe for patients than it was before. We need to equally look at other markers of quality and outcomes for treatments and make sure that they are at least as good or better. Access, again, going back to the Devon, uniqueness of Devon, access can be a real problem for some parts of the county, and we are looking in great detail at the effect that a change in service might have on access for people who live in some of the more far-flung parts of our county. And there is a lot of time and effort put into determining travel times between the various sites of healthcare. Service sustainability really refers to the workforce that we have and making sure that there would be no point in designing a service which actually we couldn't staff and sort of fell over within 6 months of being set up. So service sustainability is absolutely key, and of course in itself links back to safety and affordability. We've also agreed that it's crucial that we develop training opportunities within Devon, and this is it applies to doctors and nurses and other health professionals, but crucially also to people who work as carers. We do have difficulties recruiting carers in some parts of Devon, and providing really good training and a well-structured career progression is going to be important to get people in and to keep people in those jobs. Cost effectiveness, of course, is important. The video demonstrated the financial aspects of this and why. Another reason why we need to change. I think it's important not to overstress that, though. I've described the fragility of some of our services, and our prime aim is to make sure that we have resilient services and safe services. Having said that, if they are resilient and safe, they will probably cost less because we're not having to prop them up with temporary staff and deal with unintended consequences. And at the bottom here, they're not at the bottom because they're less important. Of course, patient choice is important, and we would always want patients to have a choice of their provider. We have agreed, however, that in the maternity review that patient choice would take second place to patient safety. And I'd hope you agree that that was an appropriate decision. And user experience, I think if we design services that are well structured, well run, well resourced and so forth, then user experience will be better. So those are the details of the criteria that we've been looking at, and I think at that point I'll hand over back to Kevin for some questions.
Driven entirely by money now, and an absence of money.
Thank you very much, Don. Yes, good ones.
Okay, thanks for that question. And we'll try and take bits of it, and if we miss any bits out, come back to us so that we know. Should we start with the money? So, you're right. I'm not going to argue that we shouldn't have more money within the NHS. My role as Chief Officer is I am given a budget and am obliged to work within that budget to buy the services for this population. We know if you look at GDP funding for the NHS compared with most of our European colleagues, we are much lower in terms of the funding. And we also know that in other areas, other countries, they rely on alternative funding streams such as insurance. So I agree with you, and we do have meetings regularly both with our MPs and with NHSE, who hold the strings for this population, as to what are the reasons why we should have more money, and most of that is around the capitation weighting system. There's a calculation based on the numbers of people in your population, the age of those population, and various other factors like deprivation that decide how much money we have as a system. And as I say, we therefore have to live within that system. As a public employee, that is my duty. So we therefore have to make sure that we use every penny of that as effectively as possible to deliver effective service. And that's part of what we aim to do in our daily lives and part of what this SDP is due to review. I'll hand over for the second part, which is about beds and care model, wasn't it?
So we've just swapped around. So we're going to pick up the integrated piece. So in terms of integration and a health service which is disparate in terms of a range of different providers, public and private sector, I think there's a real opportunity with the way of working within the STP. Nick has already explained to you about how we've come together and are working in a very different way alongside the clinicians as well. And it's very different, a very, very different way of working, much more collaborative. And I think there's a huge opportunity in terms of doing the right thing for our local people. So whereas before we've had much more adversarial behaviour around commissioning and agreeing contracts, actually there's much more collaboration. So yes, it feels much more positive as we move forward.
Thanks, and I'll carry on with the excuse me if I've got a voice. I'll carry on with the theme of integration in the sense that integration of services allows us to work in different ways, and what it's allowing us to do in South Devon is to reduce our dependency upon bed-based care. The traditional way of looking after people has been within beds in hospitals. In fact, when we went out to consultation 3-4 years ago, most people said that they preferred to be at home, and there's this concept of the best bed being your own bed. And actually, a fairly high proportion of people within our hospitals, within the community hospitals, but also to a certain extent within Torbay and at the other acute hospitals in Devon, don't need to be in hospital at all, and they're only there because they're waiting for something else to happen. So that is not only expensive, because hospital beds are very expensive to run, but it's also not good for patients. We know, particularly for elderly patients, that being in hospital leads to greater risk of becoming more confused, losing physical mobility, and of course being prone to picking up infections. So there is good evidence that it's safer once you get to a certain point in your recovery from an acute illness to be at home rather than in hospital. So I think it makes good sense actually to be less dependent on beds. And actually over the years that I've been at Torbay, we've reduced the number of beds to almost half what we had, and we have twice the number of patients going through them. So I think that just demonstrates that there is a different way of doing things, but that requires services across the whole health and social care community working together more effectively. I think the last bit of your comment was about stroke and young people with strokes, and it's really, really good to hear that you've got a project going there to help those younger people. I agree, it's a group that is not well catered for in Devon, and I think that often is the case when we have relatively uncommon conditions. It's harder to provide those good services for a smaller population. And I think it's particularly important that you mention that, because one of the key features of what we're trying to do, working with through the STP, is to develop relationships with voluntary organisations and charitable organisations to make the best use of the resource that we have in the community. We know there are enormous number of voluntary organisations out there. We haven't been very good at linking with them and helping to support them to do what they want to do for patients.
Thank you. Yes, gentleman at the front. There we go.
Thank you. I'm Pierre Landell-Mills, and I'm from Dartmouth Patients Group. I have two related questions. One of them is the question of best practice. If you're on the circulation list for NHS choices, you read almost every week examples of things that have been done brilliantly elsewhere, where they've saved large amounts of money, have delivered much better outcomes and so forth. So one wonders why, or to what extent, you are drawing on those experiences, and I mean, why outcomes are so different in different parts of the country, and to what extent this learning from what's been done elsewhere is really being captured in what you're doing now. That's the first question. The second is that we're told again and again that the real problem is getting together care packages. At 20 to 30% of patients are in hospital and needn't be there if they could only be got out, but you can't get care packages. We all have experiences of knowing people who are in that situation. Best practice elsewhere says that it should be an integration of social care and health care. But in Devon, we seem to have some difficulty achieving that. If we know that that's best practice, if it's obvious that it costs more to keep people in hospital, and if we could only get them out, the money that you'd save would more than pay for the care many times over. What is holding up copying what has been done in other parts of the country where they've had enormous success in integrating social and health care, and why in Devon, apart from apparently in Torbay, and even there it seems to have run into lots of problems with the way it was run. I mean, why, for example, between Devon County Council and say our locality, which is more to see, I mean, why isn't that in place? I mean, what is being done to get it in place?
Yeah, thank you for that. I think actually to talk about the second part first, we are actually held up as one of the examples of good practice in terms of integration. So it's true to say that that integration is greater in Torbay than it is in the South Devon part of our patch. But actually we are almost unique in having, within the organisation that I work for, in having health and social care, adult health and social care across the acute community pathway. So I think actually we are held up as being those who are doing good practice, and actually our levels of difficulty in discharging patients from hospital over this winter have been amongst the lowest in the country. So I think actually we are at the forefront of that, and the plans that underpin the community hospital changes that we're going through at the moment are exactly about that. So we have invested £6 million, or it will be the full year effect with £6 million in community services to provide that better integrated care so that we are able to get those people out of hospital. Now, it takes, there are more challenges in some respects in the more rural areas, and in particular in terms of getting carers. Just because of the sheer numbers of people, I suppose, and the younger people who usually provide those services, it is more difficult, and we are focusing on that task so that we reduce the difficulties. I've forgotten the other bit of the question now. Oh, yeah.
Yeah. So I'll pick up the bit about best practice and innovation, how we adopt best practice. So I think you're right, Pierre. I don't think the NHS has been brilliant at that historically. I think so often organisations have worked in isolation, and I can speak as a GP where you run your own practice, but you do it mostly, historically, in isolation from your colleagues. But I think we have got better at that, and I think I can point to a couple of examples. So first of all, to get best practice, you rely on innovators to demonstrate and pilot aspects of care. So we are what's called a vanguard site, one of 11 in the country around urgent emergency care. So one of the aspects of urgent emergency care was that when people ring 111, invariably there is a complex system and they don't get the advice that they require. So as part of the vanguard site, we've introduced clinical triage, so you get access to a clinician who can direct you to the appropriate services or give you advice. That now is being rolled out nationally, such that when you ring 111, you can be directed to get clinical advice, not just layperson advice. And similarly, there are meetings that I go to and my team go to share practice. And similarly, in Rob's organisation, because of the specialty networks that Rob would deal with, there would be those opportunities to adopt best practice. We've also got, please see Joe Roberts, who works in my organisation, who is here as a resident rather than as a member of the CCG, I think, are you? Yes. Who is our innovations lead, links closely with NICE, which is the National Institute of Clinical Excellence. And the whole point of that is that NICE is there to determine what is the best practice, and therefore Joe's role within my organisation is to ensure that those best practice is adopted and innovation is fed into the system. So I'm trying to paint, no, I can paint to good examples where it happens. I'm fully prepared to accept that it is not universal, and I'm fully prepared to accept that things do go on elsewhere in the country and we're slow to change. Trying to change the NHS, is reminiscent of turning around an oil tanker. It's surprisingly strange, slow to adopt. And I pointed to the IT examples around why don't we have more healthcare apps when every single other Google and other organizations allow you to access. And part of Joe's team is also specifically to look at adopting best practice around IT innovation. So I don't think historically we've been good. I think we're getting better. And actually the SDP is an opportunity to at least bring organizations, bring our four acute hospitals together and actually start talking, when we talk about stroke, what is the best way of managing stroke? Why perhaps do you get a better result for our patients in one place and not in the other? Is it around culture? Is it around funding? Is it around staffing? And to actually understand that, to be able to improve it. So I think we've got a real opportunity to address it, but I don't think historically it's been brilliant.
It's working? Yes, it is.
What are your planned changes in maternity, and what are you planning to do with McCullum Ward that's closing on the 1st of April?
Yeah, I think that was definitely me. From the maternity point of view, the STP review is ongoing. What we are doing is looking at a variety of scenarios for how we could, in theory, provide maternity care in a different way to provide more resilient services so that we don't have those gaps or potential gaps in medical cover in particular. So what we've done is we've pulled together all the possible things that you could imagine, from one end of the spectrum being where we are now, to the other end of the spectrum being one service for the whole of Devon. And we have looked at the practical difficulties that might be encountered if you change the service, the way services are organised. So we haven't yet come to any definite conclusions. We have some potential scenarios. I think I wouldn't be betraying any confidences to say that to change the way things are will be very complex, because it would result in large numbers of women travelling, in some cases very long distances. So but we're looking at that in great detail. So there are no immediate plans to change the configuration of maternity services. In terms of McCullum Ward, there has been some confusion about this, because McCullum Ward is the ward at Torbay Hospital which deals with gynecology and breast patients, and has been a very successful ward which has provided great care. We've had feedback about this to a large number of women over the years. It is not maternity, so there has been some confusion in the press about that we're closing maternity unit. McCullum Ward is, the physical space is going to close, but the function, so the team and the services that ward has provided will continue, but within another space in the hospital. So in a sense, we hope that apart from the fact that it will be a different ward that women will need to go to for that care, our intention is that they won't notice any difference in the service that they receive.
A lot of what we've talked about is focused on the integration of social and acute healthcare, and obviously in South Devon we've got the ICO and we're really pushing forward with that, but that doesn't really, I mean, we could make significant the idea is to make significant savings and improve services for those particularly elderly population. But this evening we've had the presentation around the acute service review, and I can't see obviously how we can make those significant savings around services such as A&E, stroke and maternity, which are services that aren't necessarily are services which you need immediately, so need to be widely distributed across the whole of Devon. And it seems as though the government has set not only Devon, but I suppose across the country, an impossible task. They've set us up to fail. They have cut the services and funding so that we are now in a position where we don't have enough trained doctors to provide a safe and adequate service across the whole of Devon. So we are now then set a task of actually solving that problem for the government, which they have created for us.
Certainly start with that. I think we'd all like it if the government said healthcare could have a lot more money over the next few years. I don't see that that's likely to happen in the immediate future, and even if it did, it wouldn't help us in all respects because it would take a long time to train the doctors and nurses and other therapists and specialists who are required to provide some of the services that I've described. So we still have to work out ways of using the money that we have more effectively, and in particular to develop more resilient services. So in that sense it isn't all about the money, although I suppose one could argue that if investment over the last 15, 20 years had been higher, then we might have been in a better position. But I think part of the job we have to do is to make our services better for staff as well as for patients, because in that way we can attract more people to Devon, to work in Devon, and to keep them working in Devon.
I suppose I'd just like to add something more about the workforce, because as you say, is it around the doctors that we're training? And I think it is partly that, and there is a commitment now, particularly around general practice, my speciality, to train more doctors, but that takes 8 years before those students go through and become practicing GPs. But more the concern for me when I talk to my GP colleagues, and I've been at a meeting tonight, before I came here tonight, with some 60 GPs talking about sustainability and transformation plans, but talking about the primary care element of it, which I lead on. And the more worrying aspect for it is an awful lot of GPs of my age are leaving the profession. Many of my peers already have and are intending to do so. And the other aspect is that we lose roughly 25% of women from the profession before the age of 32. So that's particularly women who've gone through training, got themselves into practice, and then are leaving, never to come back. So I think there's something fundamental we've got wrong now around primary care, around how we use the service, how we deliver the service, and how we sustain those GPs to keep doing the job which we all need them to do. And I would extend that to practice nurses and other allied health professionals in primary care. So yes, we can look to the government about failings maybe around workforce, but I think we also have to look to how we use that service and how we develop that service, and that's what I was talking to my GP colleagues around today. So that's just to sort of put it in context, that that's another piece of work that the STP needs to do when looking at particularly around primary care delivery, and Rob's already highlighted the issue around workforce in those specialist areas.
Recently in my school, a girl had died of leukemia. If she had survived, how would she have been cared for in Torquay if action had been taken place and she was recovering?
Thank you for that question. none of the proposals that we're talking about tonight would affect the services that your friend would have needed when she was ill. So children's services that we are looking at across Devon are really the more general emergency services. So a child who was taken ill in the way you describe would end up going to a more specialised service. And actually the service, that at the moment would be in Exeter, and there's no intention to change that. So I think it is a challenge, and it always has been, and always will be within Devon, to provide some of those really specialised services, and children with leukemia and that sort of thing is not a common, thankfully, not a common occurrence. So it's always going to be a challenge in Devon to provide that. Annette pointed out before that there's an issue about the number that services have to be designed in such a way that the doctors and nurses have enough experience to really be good at what they're doing. So it would be no good for me to see a person who had a child who had leukemia because I had no experience of doing that. And so we have to focus some of those specialised services in centres where people have the most experience, and that's always going to be the same. I think it does have an impact on how we provide some of these other services there, and it comes back to the stroke services, where we really need to be sure that people are seeing doctors and nurses and therapists who have the right expertise, so that they're getting the best possible care.
If I take one or two more, so if I take that gentleman and this lady, is that okay? And then we'll go into the sort of small groups.
Sorry, Robin Springers, I'm a town councillor in Dartmouth. I'm quite concerned about the care in the community. I must admit I'm less concerned about what is happening in the health service. I'm concerned about moving people out and into the community, because I don't think that they are being well supported. I'm very conscious that most of the people working in the community are low paid. They're often poorly trained. They're employed by private companies, private organisations, and those organisations, and I'm talking here from people I've spoken to in my area, their employers won't let them go and get better training. They won't let them move up the scale. And I think I'm generally supportive of what you're trying to do, but I think the really poor link in the chain that is going to cause it to collapse is that you will not have the care in the community. So I just would like some reassurance that something's going to happen there.
I think you're absolutely right to highlight a concern, and it isn't a new concern. It's been a concern throughout my practice as a GP of patients who have needed social care packages and haven't been able to access them, because that's a highly responsible job, looking after somebody at home and tending to their need. There's travel involved as well, and if you can earn more stacking shelves than Asda, why wouldn't you? Add to that the rurality of our population, therefore your workforce is more dispersed, and the problem becomes even greater where you are in the South Hams. So so in Torbay, by combining the health and social care budget, it has generated some benefits, because the ICO can fund and support carer training and development, and that happens so the carers are formed part of that multidisciplinary team. There's a sense of collegiality there for the individuals, so they feel supported. There are also opportunities to take part in the training that the ICO delivers for its own staff that the carers can similarly attend. So there are those opportunities to develop, and that pathway of moving from carer to more senior posts to eventually move in and be delivered nurse-style training. So those bits are more easily delivered in Torbay. For Devon County Council, which covers South Hams, we're pleased that Devon County Council Adult Social Care has now recognised that travel needs to be paid, otherwise you will not attract carers. So that now happens within Devon County. We're also working with people like Pennington College to actually develop a workforce within our own young population, so it's sort of from your community, for your community, and to be valued within your community. And so those discussions have gone on and is being implemented in the Bay, but again, those discussions are also going on within Dartmouth College in places whereby actually we need to bring young people from the local population to stay in the local population, be valued by the local population, work with the multidisciplinary teams, and work with the voluntary sector, because we recognise that part of caring, and for my practice, we had our own group called Sharing Care Ipplepen, which is the practice I work with, and we relied very much around that loneliness and around support for frail elderly at home, who would work in conjunction with social services. Now you could argue, well, you shouldn't need to pop up social services, but you're a realist as well as I am, that actually where you have that voluntary sector, and if you can support it with small amounts of funding around training and around some sort of management support, then actually people are fantastic, and Dartmouth Caring is the case in point as well, where we can actually use our voluntary sector to work alongside a very challenged care sector. So there are things to be initiated, but ultimately we need to be moving resources out into the community to get those placements to allow people to be supported at home. Do you want to add anything, Devon?
Just a final example really was around our western part of our patch around Plymouth, and actually how the City Council there are focused on ensuring that the people are paid the living wage rather than minimum wage. So there's something around a real focus. There's a number of things that are happening across the whole of Devon, including Plymouth, which bit by bit are incrementally improving the situation. But again, it's back to the innovation, seeing it work in one area and then adopting that and spreading it across the rest of the county.
Could I just ask about the timescale? Obviously, we're here discussing sort of what the criteria are that you want to formulate the plans on the basis of. But what is the timescale for formulating those plans and rolling out a consultation? There was a lot of hype about everything closing down from the 1st of April, maternity, paediatrics, which obviously isn't going to be the case. But it would be useful to know, especially when wanting people who couldn't be here tonight who asked me to feed back to them, letting them know how to feed back into you and what timescale.
Thanks very much. Yeah, the timescales for the reviews that are going on is that they are due to finish by the end of April. But what that means is that we will come forward with a series of scenarios and suggested possible changes in models of care. Then that would be that we need to do more work on those. So there would be questions about, if we were to change care in this way or that way, we would have to work out what the impact of that would be, what the potential costs would be, if there was more building work needed, and so forth. And so that's going to take some time. There may be some things that we can do relatively quickly, and those will be things that won't be noticeable to the public in a sense. So if there are different ways of working that we've identified through the reviews, we will get on and do those as quickly as we can. But anything that requires a substantial change in where care is delivered would need to be subject to a public consultation. So then there's quite a formal process then that's built into that. So nothing's going to change very quickly. I think there is quite a lot of information out there about what's going on. Unfortunately, people hear scare stories, and I think they do also mix up. There was the question about McCullum Ward and maternity, which are sort of almost two aspects of a similar service, and the press have mixed those two things up, and so I think that's how some of these stories develop. But there is certainly no plan for changing services at scale in the short term, and there may not be any change in the services as far as people see them. That depends on the outcome of the reviews and then consultation if it's needed.
Yes, thanks everybody. First of all, thank you for asking all those questions, and really interesting ones, and the ones that I particularly wanted to ask myself, so thanks on that. And thanks to the panel for responding very honestly on those. Could I move into the second part of the meeting now? Now, on each one of your tables, there should be a facilitator. If they can put their hands up, identify themselves, or whoever hold their piece. What I'd like to do now is move into that second session, which is really your opportunity to actually discuss amongst yourselves some of the issues that we've raised. The facilitator will be sort of guiding that, and we'll be taking notes down. Nothing is going to be lost. Now, there's a few tables where it's only got one or two people on, so if the facilitator would like to merge with another table, please feel free. And we'll give this one about half an hour, and then we'll just close the meeting. So I'll say, yep, carry on. Thank you.